I'm Manoj Karmakar. Welcome to ISSPS TV. I hope you're enjoying the videos. If you like any of our videos, do remember to share with your friends. Also, do remember to subscribe so that you can get regular notifications of any future uploads. In this next video, I'm going to discuss with you ultrasound imaging of the lumbar paravertebral region relevant for lumbar plexus block. Now enjoy the upcoming video. During this session, we're going to dive deep into ultrasound imaging of the lumbar paravertebral area. I will cover that in the next 30 minutes. I'll be followed by Dr. C.P. Lin from Taiwan. He will cover the ultrasound imaging of the sacrum and injection techniques related to that region. And this will be followed by a live demonstration by Dr. Stanley Lam. He will hopefully highlight many of the things that the previous speakers have spoken about and that we will be talking about during this session. And then that will be followed by a Q&A session. So now that I'm dealing with the lumbar plexus and ultrasound imaging of the lumbar paravertebral area, if you just give me a second. Okay, my objective is to review the anatomy relevant for lumbar plexus blockade. Then I'll demonstrate to you how to perform a lumbar paravertebral sonography. Then we'll discuss a little bit about the different lumbar plexus block techniques that are available today and whether you should be using the transverse or the sagittal scan techniques based on the available evidence. So when we talk about the anatomical considerations, the lumbar plexus is formed by the ventral rami of mostly L1 to L4, but it could be prefixed and postfixed by T12 or the branch from the L5. This gives off the nerves that are a part of the lumbar plexus, which are the iliohypogastric, ilioinguinal nerve, the femoral nerve, the obturator nerve, and the lateral femoral cutaneous nerve. So when you're performing lower extremity blocks, then lumbar plexus block forms one part of the innervation of the lower extremity. So unlike the upper extremity where you can do a brachial plexus block and anesthetize majority of the components of the upper extremity, in the lower extremity you have another major plexus, which is the sacral plexus. So today we are talking about the lumbar plexus. As you can see here, these nerves, after they emerge from the intervertebral foramina, are actually located very close within the psoas muscle, and they are on the posterior part of the psoas muscle. This is it's often described as the psoas compartment. So this is in the lumbar paravertebral region, and you can see here after dye injection in the image to your right in a cadaver that how it has stained the lumbar plexus nerves within the psoas muscle. These nerves are indeed not small nerves. They are relatively large-sized nerves as they traverse through most of the bulk of the psoas muscle, lying mostly in the posterior part of the psoas muscle. Farney many years ago demonstrated that the formation of the lumbar plexus within the psoas can be very variable, and various different combinations eventually take place within the psoas from individual to individual. But then the three major nerves, which are the lateral femoral cutaneous, the femoral, and the obturator nerve, are given off from this plexus of nerves. Also, the arrangement of the location of these nerves within the psoas can vary, as you can see here. If one were to be the lateral femoral, the two were to be the femoral, and three were to be the component that makes up the obturator nerve, you can see that they do not always lie within a singular compartment. It can be isolated, and that is what anatomy is about. It is a variation, is the spice of life, I guess. And you can see that how they take different forms in this axial section of the psoas muscle. We have found the Visible Human Project dataset very useful when you can sit in the comfort of your home and dissect the human cadaver model that is available using various different softwares or online softwares. And you can study the anatomy millimeter by millimeter in all the different planes. You can see As you can see here, you can do a cross-sectional, transverse, sagittal, and the coronal plane. And I urge those of you who are interested in this to look out, and you will find it. So when we do a lumbar paravertebral scan, it's usually performed at two different levels. If you imagine, we are doing the scan at the level of the transverse process. So you can see here, this is a transverse process at the level of the L4 vertebra, but it's at the level of the transverse process. Posteriorly, you have the articular processes, the articular pillar, and the transverse process, and the vertebral body anteriorly. And here you have the psoas muscle, which form majority of the bulk. And laterally, you have the quadratus lumborum muscle. And posteriorly, you have the muscles that make up the erector spinae group of muscles posteriorly. If you go a tad lower to this level, then you come to the intertransverse level, which is at the level of the articular process, as Professor Feigl alluded to in his presentation. The articular process you can see here are shorter, and anterior to the articular processes, you will see the intervertebral foramina. That's where the lumbar nerve roots, emerge from the intervertebral foramina, or if you remember what Professor Morrigal said, this is not often a foramen, it is often a canal, and that's very true. You can see the nerve root as it's formed, and it's enters this, the spinal nerve enters this intervertebral canal, then immediately gives off the dorsal branch, and the ventral ramus actually does not enter the psoas muscle immediately at the same level. So the analogy is, don't consider this like the intercostal nerve, which enters the paravertebral space and the intercostal space almost at the same level. In contrast, at the lumbar region, the ventral ramus actually dives downwards and it enters the space below. So you can see here, this is L4 vertebral level. This is the lumbar ventral ramus. So you can see the L3 nerve root, or the ventral ramus, part of the ventral ramus is within the fleshy part of the psoas muscle posteriorly. But this is indeed the nerve from the higher foramina. So you can see it has emerged above and it's now descending within the psoas muscles. For the same reason, this will go on to join the L3 at a lower level. They then come to lie in this ventral ramus, and that is your psoas compartment where the nerve roots fuse. You also see that how in this coronal section, anatomical section, and the coronal MRI, you can see how the nerve roots, after they emerge from the intervertebral foramen, actually take a steep caudal route to crisscross and join to form the lumbar plexus within the posterior part of the psoas muscle. So they are, in fact, located in the posterior part of the psoas muscle. This is often described the psoas compartment because it is indeed between the anterior fleshy part and the very membranous posterior part. So most often the plexus will be located in this intramuscular fascial compartment, which is the psoas compartment. Also, you will see here in this sagittal scan, we can perform a scan to look for the psoas muscle. You can see here, this is a sagittal scan, anatomical section going through the various transverse processes and the sacrum. These are indeed the transverse cross sections of the transverse processes, and you can see the plexus nerves are within the musculature, within the posterior part of the psoas musculature. So multiplanar anatomy can also be useful in understanding the anatomy. So one of the advantages of using the visible human server is you can slice up the anatomy in different planes, and then you can look at the same structure in a multiplanar view. As you can see here, this green crosshair has been placed on the L3 component of the lumbar plexus, and we can immediately see it in the same location in the sagittal plane and in the coronal plane. So you can see here, this is the same point in this different in the different anatomical sections, but you can validate what you are seeing, and you can see its relationship to the different. So you can see in the sagittal structure section to your left that the lumbar plexus nerves are indeed located in a very thin membranous compartment in the posterior part. So the posterior part of the psoas muscle is indeed very thin and membranous. So what kind of equipment do you need when you perform a scan? Needless to say, because it's a deep structure, we use low-frequency transducers, and low-frequency probes are by far the transducer you got to use. You can, there are all kind of different machines available today. In the interest of, I don't have any financial interest, but a machine that allows you optimizability is the buzzword. So you should have a system, unlike a point and shoot camera, you're not going to get a good image all the time. So you'll have to have a system that allows you different optimizing features so that you can get clear-cut images of not only the psoas, but also the nerve roots and the lumbar plexus. Today, the lumbar plexus paravertebral area can be, the lumbar paravertebral area can be imaged in the sagittal as well as in transverse planes to define the anatomy relevant for lumbar plexus block. The Trident scan, we describe the sagittal scan looking for the sagittal view of the transverse processes and the psoas muscle, which was eventually just defined as the Trident view. So when we refer to the Trident view, it will refer to the sagittal scan. You can also do a transverse scan to define the anatomy, a lumbar paravertebral anatomy. While we describe the transverse oblique scan, the Shamrock scan is getting more and more popular, and I think provides good view of the relevant anatomy. So as you can see here, from your left to your right, to the right is the Trident view. Then we have the Shamrock view in the middle with the very prominent transverse process of the lumbar vertebra. And then this is the intertransverse view, is the paramedian transverse, but it is an oblique scan, giving you quite a good view of the not only the articular process, but also the part of the exit foramina of that lumbar vertebra. So let's start with the sagittal view. The sagittal view was originally described by Lucas Krichmeier and their group in a cadaver study, but because they were cadaver images, they were not really very clearly discernible, and we presented our clinical work in that respect. But you can see here the ultrasound transducer is positioned in the sagittal view about 3 to 4 centimeters from the midline. So it's paramedian and it is sagittal, and it's about 3 centimeters paramedian and just above the level of the intercrystal line here. This is how the ultrasound beam is insonated. You can see the green arrow. This image would insonate not only the posterior paraspinal muscle, but also the transverse process in the psoas muscles anteriorly. In this multiplanar CT image of a phantom, you can see how the ultrasound image traverses or projects your transverse processes in different planes. So when you look at the anatomical view, this is the sagittal anatomical section. We are imaging the anatomy in this plane, and we're aiming to see the transverse processes and the psoas muscle anteriorly. So when you see it, you can see that this is in the phantom image. If you remember from our webinar on lumbar spine, they produce a cross-section view of the lumbar transverse processes, and because it is bone, they cast a shadow. These shadows, in fact, are the acoustic shadows of the transverse processes. And if you have determined the level of the scan by looking at the lumbosacral junction, as we discussed in our previous webinars, then you will know that these are the L3, 4, and 5 are transverse processes. And in the acoustic window of this lumbar ultrasound Trident, you can see the psoas muscle, which is located in this Trident here. So let's take a look at this video image where you can see the acoustic shadows of the lumbar transverse processes. In the acoustic window, you can see the psoas muscle. In fact, you can also see the anterior border of the psoas muscle, which is this hyperechoic area. So anterior to that would be the retroperitoneal structures. Thereafter, you can look at the posterior part of the psoas muscle. You can see here there's a hyperechogenic line, which represents the lumbar plexus nerves in this particular subject. As you can see here, I've just put in a correlative image for you to look at. These are the CT views of the L3, 4, and 5 transverse processes. And then you can see how the transverse process casts a shadow, and the lumbar plexus nerves that are within the within the fleshy belly of the posterior part of the psoas muscle can be delineated posteriorly. So these are the lumbar plexus nerve that you will see in the posterior part of the psoas muscle. And this is the basis of how we perform lumbar plexus block using the lumbar ultrasound Trident. But it is important to remember that not everything hyperechogenic within the fleshy psoas muscle is a nerve. Actually, the psoas muscle is known to have many intramuscular tendons. These all join together to form the psoas tendon more caudally, but within the musculature, there are tiny fibers of these tendons that eventually fuse to form the psoas tendon. So these are the intramuscular tendons within the psoas. So be wary when you see an ultrasound image and you see a hyperechogenic structure. It may just be a little intramuscular tendon. Nevertheless, in this acoustic window is where you can see the ultrasound view of the lumbar plexus. And this is the ultrasound Trident that we described as the Trident sign, and is based on the Trident of Poseidon, the god of the sea in the Greek mythology, or the Trishul of the Hindu god Shiva. So it's a good sonographic pattern to remember when you're performing this scan. Now, the question is, can you visualize the psoas compartment? Now, I showed you that you can see the psoas, the lumbar plexus nerve within the psoas muscle, but can you visualize the psoas compartment within the Trident? Occasionally, in some patients, you will see in the posterior part not only the nerves, but if you have a system that allows you optimizability, and if you can use some high quality zoom, then you can see here, you can indeed see the lumbar plexus is located in a hypoechoic space between two hyperechogenic lines, which are indeed the part of the epimysial layers of this muscle. And you can see the nerve root that forms part of the nerve that forms the lumbar plexus in this psoas compartment. So the Trident views can be used to perform lumbar plexus block, and this is the technique that we have described. And what it involves is performing a paramedian sagittal scan, as I described to you, like so. Insert a needle in plane from the caudal to cranial direction, so much so that the needle is inserted into the posterior part of the psoas muscle. And because this is a deep block, we often combine this with nerve stimulation, and you are looking for ipsilateral quadriceps muscle contraction. Thereafter, you inject the local anesthetic. And I will show you more details about the psoas compartment and the nerve in the coming in a short while. So then you can do a transverse scan. You do a paramedian. It is a transverse scan, as Lucas has demonstrated many years ago in cadavers. They did the sagittal as well as the transverse scan. Because they are cadavers, so the anatomy sometimes can be a little more difficult to discern, but you can see he has demonstrated the articular process, the vertebral body, and the relevant muscle, which are from posterior to anterior. You have the erector spinae, the quadratus lumborum laterally, and the psoas muscle anteromedially here. He also demonstrated that you could insert a needle from the medial aspect and use the ultrasound beam as though you are looking at how the needle enters the psoas muscle from posterior to anterior, and place the needle in the posterior part, and illustrated with CT that the image indeed provides you good targeting of the lumbar plexus nerve. We just modified this slightly to allow better visualization of the needle to perform not a true transverse scan, but you can see here this is a paramedian, it is a transverse, it is an oblique scan. Now, this is a transverse oblique scan at the level of the transverse process to your left. Now, obviously, the transverse process is going to cast an acoustic shadow and will obscure the lumbar plexus within the posterior part of the muscle. So if you just imagine you slide the transverse slightly caudally till you are in the intertransverse window. So on your right is the intertransverse window where you are now no longer seeing the transverse process, but you can form an anterior to posterior on the osseous part. You can see the vertebral body, the intervertebral canal, the articular process, and the spinous process. So this actually provides an unimpeded access to, for the needle, not only through the erector spinae muscle, group of muscle, but also into the psoas muscle. And this is the basis of performing lumbar plexus block using this. We've also demonstrated using correlative, anatomical, and magnetic resonance imaging that when you perform a paramedian sagittal oblique scan at both the transverse process and the articular process level, you can have a very consistent way of identifying the anatomy relevant for lumbar plexus. Now, this is the objective is to identify the paramedian transverse oblique window at the level of the articular process as seen on the image to the bottom right. You will see here in the fleshy psoas muscle in relation to the anterior medial part of the vertebral body. And then you can see within the psoas muscle in the posterior part, there's a hyperechogenic structure, which is indeed the lumbar plexus, and the rectus spinae muscle posteriorly. However, at the transverse process level, as I alluded to before, you will see that you can also get the same image as seen on your to your right, bottom right, but the acoustic shadow of the transverse process obscures most of the anatomy that is relevant. However, if you just go between the two transverse processes and at the level of the articular process as seen on the image to your bottom right, you can now not only see the lumbar nerve root, the spinal nerve root as it emerges from the intervertebral canal and enters and the ventral ramus dives deep down, but also you can see the nerve root within the posterior part of the psoas muscle. And if you look very carefully, there's a hypoechoic, which is usually fat-filled space that goes to the posterior part, which is indeed the psoas compartment. So I showed you the psoas compartment in the sagittal view, and now you can also see it in the transverse view in this particular individual. A slightly magnified view, if you may, you can see that in the posterior part of the psoas muscle, you can see the lumbar plexus nerves, and within posterior and anterior to it, you can see a hypoechoic area which represents the psoas compartment. So this psoas compartment indeed correlates very well, or the anatomy correlates very well. The sonographic anatomy correlates very well with the anatomy you see in an MRI, where the nerve is actually emerging and enters the psoas to dive down. And in the posterior part, as you see on your ultrasound, you can see the L3 nerve has actually come from the level above to enter this level. So you can see here. So George, if you're still there, these are the intermuscular planes I was alluding to before. You can see here the rectus spinae muscle, but you can see this retrolaminar area, which is also hyperechogenic, which is fat, and the intramuscular plane that make up this plane. So you can see in another image, you can see how clearly you can visualize the lumbar plexus nerve within the posterior part of the psoas muscle. And again, this to show you the same in the posterior part of the muscle. So this is a coronal view just to show you how you can see the nerve does not actually enter the same level, but is actually going downwards within the posterior part of the psoas muscle. So this is, imagine you are looking at the psoas muscle from with the subject lying supine, and you're looking at the psoas muscle from the sky. So that is the coronal view, coronal section from a lateral to medial. You can see medially, you can see all the vertebral bodies with the intervertebral ossifications, the intervertebral discs, which are the areas where you can see ultrasound penetration. Laterally, you can see the psoas muscle from cranial to caudal. And within the medial part, you can see the lumbar plexus within the psoas muscle. So how do we perform the scan? Since we are not going to do a live demonstration on the lumbar paravertebral imaging, I would take this opportunity to show you how we perform a scan. You lie the patient lateral, you place the transducer about 3 to 4 centimeters from the midline above the iliac crest. As you can see here, this ultrasound image transducer is not only looking medially, but is also looking anteriorly. Imagine you're looking at the anterior surface of the vertebral body. So don't worry, this ultrasound image will loop around, so it'll come back to the original part. So it's a transverse, it is an oblique, and it is, imagine you're trying to see the inferior vena cava on the anterior surface of the vertebral body, because this is the right side, so the inferior vena cava is a good landmark to look for. And the structures that you will see, now let's go to the ultrasound image. From posterior to anterior, you can see the spinous process, the articular process, which is casting this little shadow. Then you have the transverse process, which is now gone. And then you see the anterior lateral surface of the vertebral body and the inferior vena cava anteriorly. Then you have the psoas muscle, which snugs the vertebra. Laterally, you have the quadratus lumborum muscle, and posteriorly, you have the erector spinae. Now, it's important to understand that this is an intertransverse window. It is not a paramedian sagittal at the level of the transverse process, because when you take the intertransverse window, it leaves you without any acoustic shadows of the transverse processes. It's also very important to remember that there are major vessels, and these vessels may be in the line of fire. And if they do come in the path of your needle, it's conceivable you may puncture these vessels. Just for a quick recap, the lumbar arteries are given off from the aorta, and then they immediately give the dorsal branch, and the dorsal branch gives off the some of the radicular branches that supply the part of the spinal cord, the vertebra, and the dorsal branch actually goes posteriorly to supply the erector spinae group of muscle and the osseous elements in the posterior part. Now, these are the vessels that may be in your line of fire. If you can see here, there are many vessels within the erector spinae muscle, and the vessels that are very close to the transverse process and the articular process. So my advice to you is that it's very tempting to go towards the foramina, but I urge you caution, because this is the danger zone. Actually, your lumbar plexus is located more lateral to these vessels, so stay away from the foramina. As you will see here, these are the lumbar arteries in this angio CT reconstruction of this CT angio. You can see the lumbar arteries, they give off the spinal arteries, and if for some reason the spinal arteries are damaged, then you can see that this can lead to post-operative neurological dysfunction. Actually, this is a study we conducted, but we still haven't published it. But it's just to show you that Doppler sonography can be used to define many of these. These are young volunteers, 30 medical students, that typical BMI of medical students. You can see that the lumbar arteries, they can be visualized very clearly, and the lumbar arteries actually follow the vertebral body. This very high sensitive Doppler here with the GE system. You can see they are indeed snugging the vertebral body. They give off the spinal arteries, which are seen very close to the intervertebral foramina. And posteriorly, you will see the dorsal branches, and I will show you more details about that. We found that the transverse scan was more reliable in identifying many of these vessels in these young volunteers. So with the sagittal scan, the Trident view, you don't know where you are performing the scan relative to the foramen or relative to the transverse process, because it is a very thin 1 millimeter plane. But when you do a transverse scan, you get a whole holistic view and a better three-dimensional understanding of the anatomy relevant for the lumbar paravertebral region. And also the visualization of the vessels are much clearer. And these visualized arteries can be in the line of fire, as you can see here. It is bang in the line of your needle. As you say, this is a Trident view, and you do an inline. You can see here that the lumbar plexus in the psoas compartment, they are significant vessels too. Also, the transverse process, as you can see here, this is a part of the dorsal branch of the lumbar artery. You can see it's very closely related not only to the transverse process, but also to the psoas muscle deep to it. You can see here the dorsal branch is a very large branch, and it's given off from the lumbar artery. So beware of these vessels, because they are all in the line of fire. The more medial you go, the more the danger they lurk. And some of the dangers are related to the radicular branches that are given off from the spinal, from the lumbar artery, beg your pardon. And you can see there are many tortuous and major vessels that lie there. So the question many of you may be saying, what should we do when there is a patient with coagulopathy? I think the answer is this red circle with a no. So this is a big red circle with a no. Yes. As you can see here, our data also agrees with the commonly voiced concern that lumbar plexus block should not be done in patients with coagulopathy. And this is the recommendation by the American Society of Regional Anesthesia, that it's in a deep area, and these are deep blocks, non-compressible, so you should not perform it. And I hope I showed you enough of the vessels to dissuade you if you are thinking about it. So the paramedian transverse oblique scan can be used to perform lumbar plexus block, as we have demonstrated. It is this acoustic ultrasound window you are looking for, the level of the articular process. And once you have identified the articular process level, you can see this is a typical arrangement of us performing the block. We use a dual guidance because the lumbar plexus nerve root may not always be very clearly definable in most individuals. So particularly the elderly, in whom you are often most likely to perform these blocks because there are safer alternatives which are more distal. So always use nerve stimulation in conjunction with it. This is just to show you that I can be ambidextrous. So you can see here we are doing a right-sided block with the patient performing an oblique scan. The needle is inserted over there. And you will see in this image that the needle is inserted in plane, aiming for the lumbar plexus within the posterior part of the psoas muscle. And as I alluded to before, we always use dual guidance. So you will see to the video on the bottom left, you will see ipsilateral quadriceps contraction when you contact the nerve. As you can see, when I swing the transducer to the sagittal plane, you can see the tip is also visualized contacting the nerve. So local anesthetic is injected after a test bolus of saline. We always recommend you should use some normal saline before you inject your local anesthetic because it's a deep area, it's a highly vascular, and once you inject the saline, you will see sonographic changes. If you don't see any change, it's intravascular unless proven otherwise. So do make sure that you can see some changes within the psoas muscle before you inject your local anesthetic. As you will see here, as we inject, you will see there is a slightly hypoechoic area developing around the nerve with the saline, and then if you use this, you can see some puff of air that goes through it. And as you inject, the whole lumbar compartment gets distended, and you can see the spread. So injection should be small amounts, 3 to 4 cc's in small aliquots. Wait, watch, and give more if everything is well and good. You can also see that the local anesthetic also spread quite extensively cranially and caudally. More recently, the shamrock technique has been described, and I think this is a very exciting approach, very simple, and I think beginners can pick this up very easily, and was described by Dr. Axel Soter and the group from Scandinavia, goes by the shamrock lumbar plexus block approach. In fact, it is indeed just a more lateral extension of what we do, except that you just put the transducer more laterally, just above the iliac crest, and aim for the lumbar vertebra. You will therefore get the same window, but with a slightly different appearance. This is the transverse process level, or you could do an intertransverse scan and you would get an articular process level. So when you are looking from anterior to posterior, you can see the transverse process. So this is a very short transverse process, so it could be the L4 or L5. You can see the body of the vertebra. Some folks have described this as a beach chair. You can see here from the transverse process to the body of the vertebra anteriorly, they have described it as a beach chair. I think the shamrock is getting irritated by my saying this is a beach chair, but this is the IVC anteriorly and the psoas muscle on top of the lateral to the vertebral body with the lumbar plexus located inside. But actually, the shamrock technique is described based on the shamrock, which is part of the Irish flag. You can see the 3 leaves of the shamrock. The leaf anteriorly is the psoas muscle. The leaf anterior laterally is the quadratus lumborum muscle, and the leaf posteriorly is the erector spinae group of muscles. So this is the video to just demonstrate that to you. You can see here that we are performing a scan just above the iliac crest. This is a transverse process window. And as you just go below the transverse process, you will see this is the articular process window. And when you look at the within the psoas muscle, you can see there are these hyperechogenic structures, which are the lumbar plexus nerve. So this view, because the beam is at right angle to the nerves, it gives an excellent view of the nerves within the psoas muscle. And this can be seen even in this young man. You can see how we're performing the scan. And as we do the scan, you will see the lumbar plexus nerve within the psoas muscle is so clearly and vividly visualized. But do note that your needle is inserted more posteriorly. So visualizing the needle initially as it comes through the erector spinae muscle can be a little challenging, but with practice, it becomes quite simple. And indeed, this is to show you a biplanar ultrasound imaging with one of our high definition systems. You can see here, this is real time at a refresh rate of about 24 hertz. You can see that we are doing the same shamrock scan, but if you place your the biplane X-plane window here, you can see these hyperechogenic structure within the psoas muscle are now shown in the sagittal view. So the image to your right is a sagittal view, the image to your left is a transverse view, and you can simultaneously not only the psoas see the nerves in the transverse view, but also in the sagittal view within the psoas muscle. And as I alluded to, they are relatively large-sized nerves. The shamrock technique involves inserting the needle about where it's seen in this image, about 4 centimeters from the midline as traditionally. But because it is inserted slightly away, you may have a little trouble. But once you marry the plane to your needle, you will definitely see it very clearly. And once it enters the psoas and placed near the plexus, you can get good images of it. And it produces a very effective lumbar plexus block. Now, which one should you be using? I have demonstrated to you both the sagittal and the transverse view. There are 2 variants of the transverse view, and the images in front of you illustrate which of these approaches you can see the lumbar plexus actually in all the 3 nerves. So when you look at the sagittal view, the limitation of the sagittal trident view is that because it's a singular 1 millimeter plane, it's very difficult to say where you are in relation to the psoas muscle with the scan. Are you too close to the foramen or are you too lateral? This is something that's more difficult to define. So therefore, if you don't see a vessel in the ultrasound window, doesn't mean there is no vessel there, because you are just not in the right plane. That's all it means. So visualization of the lumbar plexus within the psoas muscle is also best if you compare the sagittal with the transverse view. You can see here, the sagittal transverse oblique view gives a better view of the lumbar plexus within the, so understandable. I showed you that the Doppler visualization of the arteries are also better with the transverse oblique view. And this is what we demonstrated in this study that was published in Regional Anesthesia Pain Medicine 2019, comparing the sagittal with the transverse oblique scan. You can see here, this actually compared the shamrock view with the transverse oblique scan. You can see here that the lumbar plexus are better visualized with the shamrock scan. Also, the quality of visualization of the lumbar plexus are better with the shamrock scan. And when you compare them between the obese and the non-obese, in the individuals that had a higher BMI, you are more likely to visualize it if you use a shamrock scan. So the shamrock scan obviously produced better visualization, and it's understandable because the images are at right angle to your ultrasound beam. Dr. Nielsen and the group, again, for the same group, have shown that visualization of the lumbar plexus was better with the shamrock when you compared it with the lateral sagittal or with the sagittal trident view. It also produced better needle visualization, although there were no difference in block efficacy. So ultrasound-guided lumbar plexus were also performed in a volunteer study in a randomized controlled trial. They demonstrated the same thing, that the shamrock produces better views, you need fewer needle insertions, but eventually they were equally effective. So I think given these things, which one should you use? Our practice is to use a hybrid approach. It is indeed a marriage of the 2. You can see here we perform a paramedian sagittal oblique view, insert the needle very close to it. Because the needle is close to the transducer, you are more likely to visualize it. Once you visualize it, you swing the transducer to the shamrock position, and then you continue your needle advancement. So you can see here, we are introducing it with our transverse oblique view. Once you have visualized it within the psoas, you have then swing it to the shamrock position. And then once you have swung it to the shamrock position, you advance it. Use dextrose 5% because we are using nerve stimulation. So you can see here, once the needle is in contact with the plexus, we use some dextrose to hydrodissect this area, and thereafter place the local anesthetic. As you can see here in the coronal view, you can see how the local anesthetic has now enveloped the lumbar plexus nerve within the psoas muscle, produces very effective lumbar plexus block. Okay, in conclusion, I have demonstrated to you the different ways in which you can define the relevant anatomy for lumbar plexus blockade. There are different scans techniques. Which one is better is often an individual choice. But remember, although we were the ones that described the sagittal view has this limitation, as I alluded to. So the transverse views provide a more three-dimensional image of the entire anatomy. The shamrock view gives a better view of the lumbar plexus per se. You can use a hybrid view to both marry the good visibility of the needle with the good visibility of the anatomy. But remember, lumbar plexus is an advanced block. It has very few indications, good evidence-based indications. And there are safer alternatives in the form of femoral nerve blocks, obturator nerve blocks, etc., depending on what you are doing. The suprainguinal fasciailiac compartment block is another technique that is gaining in popularity because of not only its safety, but also its efficacy. So when you consider lumbar plexus block, you must give it a good risk-benefit assay because there are many major vessels in this area, and this is an area fraught with danger. So beware when you do these blocks, because these should not be done unless there is a good indication. I hope you will find this information useful. Thank you for your attention.